The typical workup for stem cell transplant, I'd say, is as follows. One, to assess the patient's disease status. Two, to assess their organ function. And three, to think of something that you probably haven't thought of as a parent, to serve as an educator role. And I'll walk you through each of these. So one, to assess the disease status. We do have cutoffs in terms of the amount of tumor, we call it tumor burden, that will allow in order to start the stem cell transplant process. Transplant can only kill so many neuroblastoma cells. If we start with too high a disease burden, with transplant, we want to go from this much tumor down to this much. If you start with way too high a burden, we may go from this much to this much. And then by the time you're recovering from transplant, it's already growing back. So there are cutoffs that we use for determining disease status. Some of those cutoffs may be based on bone marrow aspirate and biopsy results. They may be based on scans. One of these scans are an MIBG scan. Oftentimes, many oncologists, myself included, will determine what's called a Curie score. And that Curie score is what we call a semi-quantitative, meaning it's not an exact number per se, but it gives us a rough idea of the tumor burden that a patient has going into transplant. And each of us has our own cutoffs for what Curie score levels we take into transplant. There's a little art of medicine about this in terms of Curie scores and at what levels different centers will take. I'll look at MRIs of the patient. Certainly, I get nervous as a transplant physician if I do an MRI of the brain and I see that there's tumor inside the brain. I get a little nervous. Is this really the optimal patient for transplant in terms of the ability of the transplant chemotherapy to even get into the brain? So one of the first things we do in terms of working up a patient is to assess their disease status in their bones, in their soft tissue, including the brain, in their bone marrow, and then try to come up with some measure to give it a grade or a score. It's more than just Curie score. It can be what we call INRC. This is International Neuroblastoma criteria for response. Does a patient meet criteria for complete response, partial response, mixed response, stable disease, progressive disease? I think most neuroblastoma physicians, transplant physicians would agree that going to transplant with progressive disease is not optimal. It's not wise. It's not something that we would do here at our center. And I think most transplant physicians would agree with me. Conversely, patients who have complete response with induction therapy are great candidates for transplant. Patients who have a partial response are also very good candidates. It's kind of when you get into that middle zone of those patients who have stable disease at the end of their 5 rounds of induction therapy. And then there's where the art of medicine comes in terms of determining, looking at other factors too. And here's some of the other factors. In fact, I always tell patients when they come into transplant, I want to see 2 feet on the ground. The first foot is I want them to be in remission or as close to remission as possible. That's 1 foot. The second foot is I want all organs working. All right. I want no active infections. We check out prior to transplant heart function, kidney function. And we certainly look at liver function, lung function. I believe every patient coming into transplant should have what's called a GFR test. That gives us an exact number of how well their kidneys are working. In fact, we kind of base our chemotherapy for transplant off that GFR test. Same thing with the heart function. Every child coming into transplant should have an echocardiogram and certainly an EKG to get some idea of how well their heart is pumping and working overall. Every center will have what are called clinical practice guidelines. Clinical practice guidelines are not standardized across centers in North America or Europe. Each center will have their own clinical practice guidelines, which will state that a patient's lung function must be at this level, their kidney function must be at this level, their heart function must be at this level in order for transplant to proceed. Our center has our own guidelines, but our guidelines may vary a little bit from what other centers may have too. So when you want to go into, when you ask, what do we do in part of the pre-transplant workup? First thing we do is to make sure that patients have 2 feet on the ground. What's their disease status? Are they in remission, close to remission? And how well are their organs working? You want to have both feet on the ground. If a patient comes in with hopping with only 1 foot on the ground, it's going to be a tough transplant. Meaning if they come in with too much disease but good working organs, that'll be a tough transplant to get them, to get that disease burden down. If they come in with a low level of disease but marginal working organs, that transplant's going to be dang tough. We want both feet on the ground. As a clinician, we typically devote 50% of our time to taking care of our patients, with the other 50% focused on educating our patients and obviously their caregivers. It's during this pre-transplant workup that I believe strongly that the education process comes in play. When a child goes through transplant, we as the transplant physicians, we're not in the room 24/7. The nurses may be in and out, the physicians may be in and out, but it's the caregivers that are there typically 24/7. So we have to teach a parent, a grandmother, an aunt, uncle, whoever is going to be the main caregivers, to be our eyes, to be our ears, to watch that when they're there watching that child. So it's our job. We owe it to you as parents to educate you so that you know going into transplant exactly what you should be watching for, looking out for, so that when we come in, hey, Dr. Yanik, Billy is doing this, Susie is doing this. I remember prior to transplant, you said we have to watch out for this. It's our job to educate you as a physician, for us as physicians to educate you as the caregivers. We have to give patients realistic milestones. We have to give them realistic expectations. We have to tell them not just what they're going to face during transplant, but we actually have to show them those 3 steps that I talked about of neuroblastoma therapy. The first, I talked about 3 core parts: induction, consolidation, and then the immunotherapy. We have to show how transplant fits in to those 3 compartments and what's going to happen after it. I can't just get myopic and say, we're going to do 2 transplants 6 weeks apart. No, I have to show the rationale to parents where those transplants fit into the overall schema of therapy. One will do transplant, one we won't consider transplant. If we won't consider transplant, will we do a bridge and come back to transplant? I got to be able to walk patients through it right from the start.